I think it's true to say that a failure to recognise and therefore to investigate sudden onset lameness, especially when mild, often results in inadequate management. So we see recurrent short rest periods during which time the horse improves, and then it returns to work, and after return to work, lameness recurs, and therefore the horse is rested again, and we have these repetitive cycles. So then we are in the situation when we have a chronic problem which may be acutely exacerbated. So for example, in the image on the right, we can see it highlighted by the small arrows an enlarged suspensory ligament, the axial aspect of which is diffusely hypoechoic, consistent with a suspensory branch injury. In association with this, we've got an abnormal amount of fluid in the plantar recess of the metatarsophalangeal joint and synovial hyperplasia highlighted by the broad arrow. And this presence of synovial hyperplasia probably reflects the chronicity of the problem. We also see this with chronic forelimb proximal suspensory desmitis with or without enthesiopathy. This recurrent cycle of a low-grade lameness, the horse is rested for a period, it resumes work because it becomes sound, then after a period of time it goes lame again, and we have this chronic cycle. And we can even have the same with forelimb superficial digital flexor tendon injury. I think we also have to recognize that just as in people, we can have pre-existing pathological change, which has obviously been going on for some considerable time, because at the time at which you first investigate the lameness, there are obvious radiological changes or obvious changes on MR images, which have obviously predated the time of the onset or the recognition of the lameness. So this can occur with injuries of the podotrochlear apparatus and the deep digital flexor tendon. In the MR images that we see here, from left to right, on the left we see a dorsal border lesion involving the deep digital flexor tendon with a mass on the dorsal border extending into the navicular bursa. In the middle image we have diffuse increased signal intensity in the navicular bone, and there is absolutely no separation visible between the deep digital flexor tendon and the navicular bone. And in the fat suppressed image on the right, we see linear increased signal intensity in the navicular bone, extending from proximal to distal, probably reflecting abnormal stress through the podotrochlear apparatus. Other examples when we would quite commonly see pre-existing radiological changes which have suddenly become clinically apparent, but then persist, is when we have osteoarthritis of the metacarpophalangeal joint or the carpometacarpal joint, the distal hock joints, either the centrodistal and or the tarsometatarsal joints, and the femorotibial joints. I believe that we have, over the last 30 to 40 years, seen some changes in general horse management in some countries, which has resulted in changes in the reasons why horses develop lameness or manifest changes in performance as a result of pain.